All right, we'll start our meeting, our caucus. Chief Judge, thank you for coming. We're going to go over a contract with Fitch Associates that performed a feasibility study in the city of Scranton. Right.
Yeah, good evening, Council. This has been a long time in the making. This is something we started discussing probably back in 2020. And at this point now we have a study that has rolled out. And there's a number of different reasons why the city thought to engage in this study around the EMS service delivery model that's currently employed here in the city of Scranton. I can tell you from an emergency management perspective that if you called me, any one of the councilmen called me at any given time and asked me how many ambulances are on duty in the city, I couldn't tell you. The Lackawanna County Comm Center could not tell you. And under the city's charter, it's our responsibility to provide EMS services to our residents. So we engaged with Fitch Associates. They are a nationwide company that has done several of these, and I'll let Mr. Knight speak more to that once I pass it off to him. We've also have Dr. Clerk Hinckley, who's here, who's from the area, been dealing with the EMS delivery model and system here in northeastern Pennsylvania for years, and he is currently the City of Scranton's medical director for our EMS program for the City of Scranton Fire Department. So with that, I'll turn it over to Mr. Knight, and he's got about 20 slides. I actually put them up there, the study in front of you guys this evening, and I'll actually email it to City Clerk as well. Thank you.
Thank you, Chief. Good evening. Can you hear me okay?
Yeah.
All right. Excellent. So as the Chief mentioned, I have about 20 slides, so I can speed it up or provide more detail. I'll leave that to you and your preference. If you want to ask questions while we're going through it, that's whatever is your normal protocols is certainly acceptable to me. I think we have ample time. So
if you could just keep in mind we have a meeting at 6:30, so we can pace ourselves accordingly. Thank you.
Absolutely. Thank you. So a little bit background. I know the Chief gave us a high level. We're in our 40th year now as Fitch Associates as a public safety consulting firm. Our roots really started in EMS, and we've got a pretty robust public safety that looks into police and fire and EMS and air medical and all those kinds of things. My background personally, I retired from fire and EMS services, went to International City County Managers Association, was their senior manager over their fire and EMS consulting arm for a little bit before I joined Fitch Associates about 10 years ago. Have a doctorate degree from the University of South Florida and a master's degree in public administration and a bachelor's in fire and safety engineering. So a little bit of a background in that, and our firm is really robust from the standpoint that we can speak intelligently and confidently about these kinds of studies because we actually provide management services. So we practice what we preach. The types of analyses that we do and how we look at and manage systems, we actually do ourselves as well. So we get a good feedback loop from the expert consulting to actually boots on the ground, if you will. So with that, we'll go ahead and get going in the study. So the first thing I want to do, just to kind of prime, what I will share is for our firm, EMS feasibility studies have probably been the #1 ask over the last 12 to 18 months all across the country. There's a lot of instability in the marketplace for private EMS, and I kind of shared some of the primary reasons up there. Since COVID, the costs have really considerably increased and at a rapid rate. A lot of the supply chain issues, staffing issues, et cetera, have really contributed to a higher cost center than previously. And if you're not familiar with EMS revenue and cost recovery strategies, are largely capitated costs, either through negotiated with actual insurers or with the federal government or state governments, depending on how that's structured. So there's really quite a structural deficit for the cost to provide EMS versus the revenues that are available. So what we're seeing all across the country is, regardless of the provider today, most systems are requiring public subsidy in order to continue to be solvent and have a sustainable system. The rest of the equation that contributes to a lot of instability in the marketplace is the rate of hospital mergers and the introduction of venture capital as owners of EMS systems that are contributing. Some of the largest, in fact, 2 of the largest ambulance companies in the country are owned by venture capitalists, which there's been plenty of studies that speak to the efficacy of the clinical experience under that in the hospital setting. They haven't really transferred that to the emergency medical services yet. But all that to say is, with that instability or lack of stability and sustainability in the marketplace, what we've seen across the country is other boards in your position have been put in a position where they had to consider from a policy perspective, once public subsidy is introduced or required in a system, what does that mean for the level of transparency, accountability for the public dollar, et cetera. So that's really what we're going to talk through here, is how do we best define the service levels and talk through how we get from point A to point B a little bit, and then talk about the costs of what that would mean for your policy consideration. So big picture, really it's about improving the system response times, and we'll talk a little bit more in detail. The most lenient or most conservative response time value that we put together would still be an improvement on travel time, which is a time from when the ambulance goes en route until they arrive on scene, by about 3 minutes. And you'll see in a couple slides that the total response time, what we refer to as a hello to hello time, from when one of your citizens or visitors calls 911 all the way until somebody arrives on scene, that period is elongated as well, which we'll talk about. Most of our conversation today will focus on travel time, because the travel time is what is predicated on GIS analyses to talk about how many ambulances, where they need to be located, what times of day, things like that. So we'll walk through that. But really high level, to keep this moving, we really want to talk about how you optimize your staffing, how you evaluate the desired system design, what your response time parameters would be, develop objective, transparent, and accountable performance criteria so that if there is a public need for funding, that level of accountability and transparency is there, and provide fiscally sustainable fire and EMS system design that meets whatever the expectations are. So it's kind of all wrapped up together into providing a pathway for the future. So just a little bit about what the demand for services that exist in the city of Scranton. You can see that the number of incidents, including all the fire department and the EMS, was right around 17,700 calls, and that was 2022. And then the graph on the right, the figure, that's from midnight all the way over to the 11 o'clock hour, that's the 24 hours. And what you can see is during the peak of the day, somewhere around that 9 o'clock in the morning, all the way to 9 o'clock in the evening or so is your peak period. And that's a pretty typical curve that we see all across the country. It's usually 2-3 times busier during the day than it is overnight. You can see in your community that it doesn't drop off overnight as quickly as other communities. So you have a pretty steady pace of call volume. And if you couldn't make out the numbers on the top there, that's almost 3 calls an hour if you round up at the peak of the day. That's pretty consistent. This is just a heat map where we look at trying to identify where the EMS calls are occurring within your community. And you can see that the vast majority, the darker red is the highest concentration of calls, is really in the center and core of your community, and then diffuses out from there. I will say that in this perspective, though, if you are data-centric in your analyses as you look at these, the process breaks those up into quintiles. So if you were comparing this with any other study or any other heat map, et cetera, red is not universally understood. It's always just the top quartile or quintile, if you will. So let's talk about the response time comparisons. The one graph, and I won't go through that in detail, but it's just kind of the figure and schematic of the evolution of a 911 call from the time the person calls all the way until arrival. But we looked at the average in the 90th percentile, and you know what the average is. It's the mean of that normal bell curve that you're used to seeing. And the 90th percentile is really what the industry uses as a high validity measure that says 9 out of 10 times or 90 out of 100 times. This is a level of service that you can count on or better. So when we looked at the data, you can see if we focus on the 90th percentile side, when the fire department goes on calls, currently from their station configuration, they're able to arrive just over 5 minutes, so 5 minutes and 11 seconds, with a total response time from the time someone calls 911 until they arrive at 9 minutes and 33 seconds. The EMS services had a travel time of 11 minutes at the 90th percentile with a total response time of just over 18 minutes. So you can see that just the system design and structure of where the investment has been versus the fire department versus what's available on the EMS side, there's a lot of opportunity for improvement if those level of services aren't meeting expectations. There's also an opportunity to better align call processing, which is the time that it takes when someone calls 911 to process a call, validate the address, triage the call, et cetera. It's in order to get that out, to give you some perspective that the best practice, if you were doing a call triage, would probably be around 2 minutes at the 90th percentile. So there's a little bit of opportunity to improve there by almost a minute on EMS calls. And if you weren't doing any call triage, then really about a minute, minute and a half at the 90th percentile would be the goal. So there's an opportunity to improve services from that perspective in response time with a greater return on investment if you can improve the call processing. And then the turnout time many times is more of a management-related activity where the turnout time, if you're not familiar for that, is measured from the time that the crews are alerted that there's a call until they acknowledge that they're actually driving and going en route to the call. So again, that's another opportunity to reduce that back down. The national recommendation from a consensus standard from the NFPA would recommend 1 minute on EMS calls. So there's an opportunity to have a little improvement there as well. So those are two areas that have a little less cost and a better return on investment to focus on dispatch and turnout as you continue to focus on improving the total response time. So then we're going to talk about the geographic modeling. So we built out, and if I didn't say it before, I'll make sure I'm clear here. By and large, response times is a local policy choice. So in the clinical evidence-based research, there's plenty of research that coalesce between 4 and 5 minutes or faster, has a significant impact to patients with a high risk of mortality. And then after that, you have a little more flexibility, say between 6 minutes and 12 minutes in most of the studies where patients with a high risk of mortality weren't overly sensitive to the response time within that window. So you have the ability to choose where you want to have that expectation for service, and you can choose up and down the ladder where to put that. So
I'm sorry, I just want to ask where where was the data taken from to be able to get those response times? Is that from the current companies that service the ambulances and EMS, or is that from the fire
No, that was
department?
directly from the Lackawanna County 911 Center.
From the okay.
We had data extraction from them, and that's what took a large part of this study, was cleaning that GIS data.
Okay, thank you.
Thank you, Chief. So we built out, and in the GIS report, some of the technical documents that support the executive summary, we went into greater detail. But for this briefing, we're going to focus on 4, 6, and 8 minutes just to kind of lay out policy options of what you can consider. So we run what we call margin utility analysis. So if you look at the figure, what it does, and I'll draw your attention to the first one, we take each of the fire department stations using your average road speeds, your road impedance, your infrastructure that exists within your system. We got information from your GIS, and we run a 4-minute drive time polygon around the station that has the greatest or most efficient opportunity to capture those calls. So if you look at this table, the number one ranked one was truck 4. Within 4 minutes, they could capture almost 6,500 calls that exist within the system, and that would be about 43.87%. So if you just focus on the far right, I won't bore you with everybody's details, but you can see there's a diminishing return on how many calls can be captured. How that's translated for the EMS system design, as we talk about, is that you can see that you don't have to have an ambulance at every station in order to be effective. What you're really looking for is to get to the 90th percentile. So in this scenario, for 4 minutes, 5 stations could get you to the 90th percentile for capturing calls within 4 minutes. Does that make sense? Okay.
So 5 stations, meaning 5 ambulance companies located at each of those stations?
As a minimum. So that's a great question. So if you think about it from supply and demand, the supply side is how many geographic launch points do I need? That's your 5 ambulances and 5 stations. And then on top of that is the demand. So that 3 calls an hour has to be accounted for because a GIS is predicated that there is a high degree of availability of the ambulance resources, which is largely why the performance is the way it is
I
today.
don't want to get ahead of ourselves here, but so if we're talking 5 ambulances at 5 stations, are we talking 2 12-hour shifts or 3 8-hour shifts?
We designed it, we looked at it, we wanted to make sure that we weren't overly prescriptive and give you the broadest lane and flexibility from a policy choice. You'll see when we analyze this, we looked at 24-hour shifts and we looked at 12-hour shifts to give you that kind of option. I will tell you from all of the research and the, not research, the studies that we've done over the years, 12 hours has always resonated as the most efficient over 8 or 10s.
What happens during the other 12 hours?
Well, no.
Like
so,
right now, we're covered 24 hours, I believe,
Sure. So think of it this way.
with no cost to the city. Go ahead, I'm sorry.
What's that?
No cost to the city.
What's no cost to the city?
Right, all I'm saying is, right now, we don't own any ambulances. We don't operate any ambulances. We don't
Right.
insure. We don't own any equipment. We don't have hired staff for all of those, all those ambulance that you're suggesting. And we don't bear, right now, we don't bear
Yeah.
any of the risk. So I'm just pointing that out.
Yeah, that's excellent to point out. Just to clear that up, though, we're not recommending anything. We're describing the environment and the costs and the performance associated with that.
Okay.
So as I walk through this, though, to your point, at the end, we'll talk about the finances and talk about what the costs are for those policy options, and I think that will lend into what your point is.
Thank you.
Yes, absolutely. So if we move the model to 6 minutes, then you can see, and if I didn't mention it, I'll go back to 4. Out of the stations, the red squares, if you can see that up there, or on your printout in front of you, the red squares are the stations that would be needed. Any of the other stations would be above the 90th percentile. So if we move to 6 minutes, for example, now you can see that you only need 3 stations in order to exceed into the 90th percentile to meet that level of performance. So at 6 minutes, it's down to 3. And then if you jump to 8 minutes, you can see that the headquarters station is actually in the best location. So as you elongate from 4 to 6 to 8, now you can cover 96% of all the calls from the station right here.
Can you go back
adjacent.
to the to 6 minutes, the
Sure.
first slide?
Oh, sorry.
So 6 minutes. How many do you have there in the 90th?
What's that? I'm sorry.
Is it 5 stations within the 90th?
3 in this one. So you would see headquarters, truck 4, and engine 2 would get you to 95.39. Any other questions on that one?
I just need some better understanding here. So
Sure.
you're giving us some scenarios, and you're saying that the 99 percentile is the goal, right? Mm-hmm. But, I mean, tell me, what's the benefit having less and having an 8-minute? I mean, what's the best travel time? You're saying there's 6, there's different, are these policies we're supposed to have to create and live with an 8-minute response time when it's probably not, is that a good response time?
Sure.
Based on what data? Based on everywhere else it's acceptable, or what is acceptable?
Right. So
Like
let me
4,
go
6,
back.
or 8. I would want 4 myself, the age I'm at. I mean,
Yeah.
think about it.
So that was the point of talking about the evidence-based research, the peer-reviewed scientific research that's occurred in the industry. So just as a primer to go back to that, to anchor that part of the conversation, what that coalesced around is around 4 and 5 minutes or less had a better impact to patients with a high risk of mortality. So the policy conversation that's associated with that is that that group of calls is maybe 15% of your total call volume. So from a policy perspective, you're
Excuse
absolutely
me, that
right.
was extracted from the county, just the city.
Just
that data.
Nationally.
Oh, so you're just doing a national average? Is that what you're
Yeah,
saying?
on that, yeah.
But we have
the
this
evidence-based-
population here isn't really a good average. The population in Lackawanna County or Scranton, we're an aging population, so.
Yeah, absolutely. But there's lots of evidence-based research, and it all coalesced around the same findings. So there's plenty of confidence to say that that is replicable and can be applicable to here. But the point is, for you as a policy discussion, that's what you have to contemplate. What's your sensitivity to the response time that balances your willingness to assume risk as a community and how much protection you want to purchase? So you're exactly right. If I was to say what is probably the most common around the country, that's not scientific at all. I could say somewhere around 8 minutes is probably pretty typical in an urban environment. But there's communities that purchase down to 4 minutes. There's communities that purchase down to 5 minutes. I can't answer that for you, but I can anchor it into the clinical reasoning behind the response time. Does that make sense?
And
Doc, was that
what are you
fair?
saying that we're at right now?
The fire department, so let me go back to that. So this is the juxtaposition of where you are today. The investment that you have today in the fire department has positioned them well to where they can have a 5-minute travel time. So they're well positioned. And that actually gives you, from a design standpoint, if they were to do the first response for those really high critical calls and the higher severity calls, then you're really in a good position for the fire department to deliver that level of service first. The ambulance gives you a little more flexibility since you have that 5 minutes on the front side, and those are all policy choices for the chief and the city about how much or how little the fire department is going to would be engaged on the EMS side of things.
So if.
But let me
sorry.
just
I'm sorry.
finish,
Okay.
Dr. Rothschild's. So where they are is if you go down under travel in their 90th percent, the second box down under 511, that's what the ambulance is today. The ambulance is at 11 minutes.
Okay.
Right, and 18 minutes in total if you go to the total response time.
Right.
So
So you're comparing 11 minutes to the 4, 6, 8-minute
right.
plans? Okay.
Right. So as you provide structure, then you've got more opportunity to talk about what level of service you want. And then as you contemplate policy decisions, to your point, when it comes to what's the cost center between my alternative system designs, then you can at least anchor that conversation apples to apples, right? Because right now there isn't anything that anchors to performance, right? And because under municipal umbrella, police and fire is generally more of a readiness model, if that makes sense, right? You've purchased the services, they're there and available to respond when the incidents occur. When you're running it more of a business entity, an enterprise, then you have to balance the resources that you can put on the street based on what your cost recovery is and your revenue from the ambulance transports. So as you have to scale down because of staffing issues or trying to balance the books, then your response times gets longer and longer because you don't have resources pre-positioned and available. So that model will make the resources work a lot higher, I should say, and their availability will be lower. The cost of that is response time because they're coming from farther and farther away, or they're clearing calls at hospitals, et cetera, and hopping calls at a later time.
And right now, we're talking about physically putting an ambulance at stations, correct? It wouldn't be trucks going out to the scene for a call?
Yeah, the 4, 6, and 8, we use the fire stations as a geographic location. What I will say is, what a lot of ambulance companies do today, they call system status management, where they'll park on street corners, right? What we found is mathematically, there usually isn't a significant difference, especially at the response availability that you have today with the fire department, whether they're sitting at Sheets or whether they're sitting, at a fire station. So we just use the fire stations to anchor that. There's plenty of flexibility for you to decide whether you want them in or out of the fire stations and things like that, if you even get down that far into the discussion. But what it does is anchor the general geographic zone that it needs and how many resources you have to have in order to meet that response.
These are going to be actual, I'm just trying to clarify, is there any point in time when a fire engine is going to be out to a scene for an EMS call?
Yes, at some point there is, and Dr. Hinckley might be able to talk to that by the time we get done with Fitch Associates. But yes, we've identified high acuity calls where our fire department, which is the national model as it goes, backed by the IAFF, backed by the IAFC, fire-based EMS has been around for, and I'm sure that both of them would be able to talk to that, where we have trained EMTs, paramedics, we're licensed by the state of Pennsylvania where we can go make a difference. We will be going on those calls and making a difference. And we could talk specifically about some of those calls: drownings, stabbings, shootings, cardiac arrests. We won't be going on the low acuity calls where our involvement won't do anything, but with the 18-minute total response time for EMS, yes, we will be going to those calls. We're talking about a fire department that runs about 3,400 calls annually compared to where you are sending police officers who are only trained in first aid and CPR to somebody in cardiac arrest. And they run 50,000 calls a year, so it's better using the models that we have here in the city and the resources that we have available to us to be able to put them out there. And he'll be able to show some of the graphs as far as what unit utilization time looks like, and we have the bandwidth in our department to do that. Typically going on 600 line down calls. I'm talking about cable wires that tractor trailers take down right now. We're working with Verizon to get that reduced significantly. But, we will save more lives in fire-based EMS than we will ever do pulling people out of burning houses. We will have more interaction with the public and be able to do more good from a fire-based EMS standpoint, which is the national model.
So I still have a question. So you said earlier that, okay, the fire department can get there in 5 minutes, which is great. So, and then you're saying that an ambulance might take 8 to 10 minutes to get there, or even longer, correct? So the fire department's there, which is great, and depending on what medical emergency it is, they got to hang there, right? Of course, and wait. So what happens with it between 5 minutes and 8 or 18 minutes if that truck is needed on a major fire where there's a lot more lives or potential lives that might be in danger? You know what I mean? Versus maybe the broken hip, like per se, or a fall, not cardiac, but say they're waiting 8 or 9 more minutes for a fall where there's a fire where there might be other people that are in more danger.
Well, I'll take that too, Councilman. Thanks for that question. Like I talked about, we will not be going on broken hips or potential fractures or falls.
What if it's dispatched? Do they have to, say the call goes into...
I'll let the doc speak to that as far as what they have to do, but we've already had those conversations with Lackawanna County 911 director and their staff up there on how those dispatch protocols are going to be put out. But that 5-6 minutes that you're talking about, they will most likely be doing life-saving initiatives to somebody who's in cardiac arrest, somebody who has a traumatic injury, And is there a chance? Yes, there's always a chance, but that's why we have, when you look at the unit utilization times, we have the bandwidth to be able to provide this service, and it's what's being done across the Commonwealth and has been done across the Commonwealth for decades, 2 decades plus at this point. It's using our resources to the best of our ability and being able to provide life-saving interventions to our citizens in the city. And we've identified what those high acuity calls are, and we've looked at it, and even talking to Fitch, that model looks like an extra probably 1,500 calls a year for the department. That's an extra 5 calls a day, 1 per company, less than 1 per company.
So 911 dispatch will differentiate the call as to what the fire department should go to.
We are
Not
working
just,
with,
not just dispatch, because is that what they kind of
Correct.
do now? Like,
we are working
you get the
with,
call, you got to go, right? Is that how it is? Is that how it works now?
we're working with them right now to identify the national dispatch protocols, and the doc has been in that meeting as well.
Speak to that.
Yeah, I think, so it's important to realize that we have a resource already available that's not being used for medical calls, right? They're only doing fire calls and, like you said, downlines and that sort of thing. If the 911 center uses a tiered resource dispatch system, so if a fire, for example, needs 1 alarm, 2 alarm, 3, they get the resources that are needed. So if you have a fire asset out on an EMS call, it should be under our current model is going to be a priority level call. So these are patients that are kind of the sickest, handpicked to be the sickest of the sick, is where we're going to start with this, okay? And so ideally, that resource would not be pushed off onto a fire call. Does that make sense?
Yeah, so if the
So there
fire-
are other fire resources. We're not utilizing all the resources that we have, but we're going to pick the 1,400 highest priority calls within the city to respond to those calls.
So if the fire responds now, right, say they're doing that now, and that's.
Okay?
Who then calls the ambulance? Are they both
So
alerted by
the
911?
911 center is going to be in charge of dispatching
And
the
what's happening now?
appropriate
Is that
asset.
is that what's happening now, or?
Yeah, the 911 center dispatches appropriate assets, but currently, we're not providing EMS services, right? And so if you have one of these priority calls, you might currently be getting police responding to that call who have very little medical training, and they're trying to figure out what to do when the ambulance isn't going to be there for another 12 minutes.
Do our firefighters have all that training?
Every firefighter by contract has to hold a level of EMT or greater. I think we have 1 nurse, 6 or 7 paramedics, and vast majority of our staff is trained as an emergency medical technician. Anybody hired after, I believe it is 2015, has to, and that's more than half of our force right now. But
Who provides that training for us?
who does? When they go to the fire academy, they get that training. Their initial training as an EMS, as an emergency medical technician, and then we do annual refresher training and updates here in the city of Scranton.
Who does that for us?
Mostly our own paramedics now. We have used in the past CHS, Commonwealth Health, and Penn Ambulance to help provide some of that training, but most of the training we've taken under our own umbrella at this point. So we become our own CPR instructor where we can put those on, and we've put them on for the community, some community organizations as well.
So mine's part of a 3-part question, right? So first, back to those high acuity calls. Could you give me an example again of what those calls are going to be? Because we said it's not going to be a broken hip, but it's going to be cardiac.
Yeah, so let's say,
It's going to be about 1,700 calls.
yeah, and we parse those out, and we have kind of a protocol or a model for that already, to kind of work with the 911 center to parse down. There's currently 2 main dispatch levels. One is at the basic EMT level, and one is at the paramedic level. So we're taking those paramedic level calls, and we kind of parse that down to take about 1/10 of them, as the highest acuity. So who's the sickest? So seizures, shortness of breath, cardiac arrest situation, major traumas, car accidents with significant injuries, smoke inhalation, that sort of thing.
Okay, and then back to what I asked before, just to clarify, is it going to be an ambulance-type vehicle, a medical vehicle that's going to be out there taking these calls, or will one of our fire trucks be taking one of these calls?
It'll be one of the fire trucks. They're all licensed under the Department of Health as a quick response vehicle, like
Okay. And then
what's done across the Commonwealth.
Okay, and then if the injury is severe enough that at some point in time, there's going to have to be transport, how do we transport? Do we
The ambulance is going to be dispatched with the fire department. We will start the care filling that gap of where we can get there and when the ambulance is able to get there.
Okay, so the fire truck may arrive first. They're going to be providing that life-saving care until an ambulance eventually gets there, and that's who's going to transport.
That's correct.
Okay, thanks.
Can I ask you a quick question? So you said right now it's taking 18 minutes for EMS to get, and our goal is 8 or better, or hopefully lower. But what are the reasons right now that it takes 18 minutes in this area to respond? Was that data uncovered?
I'm going to let Fitch
Yeah,
respond.
let me answer it from a broad perspective and not with great specificity for your location. Generally, what happens is, like I talked about, because of the business model, if I have to be cost neutral and or slightly revenue positive, then I have to manage the resources that I put out. So if you've ever heard of minimum staffing with the fire department has a deployment strategy that's going to be met every single day. And they'll hire back overtime in order to make sure that the deployment that is supposed to happen happens every day. That way you have the readiness, and that way you have confidence and consistency in your performance. If I'm managing it against a balanced budget, then I'm going to have to make decisions day by day as a private ambulance company, and we do the same thing as we manage these depending on what the community expectations are. But I may have to only deploy 2 ambulances today because that's all that I can afford to put on the road or I have the staffing on today. And some other day I might be able to put on 4 resources or 3 resources or 6 resources. So that kind of variability in the deployment based on those financial restrictions is what happens to elongate the response time, because resources aren't staged and available for your utilization.
Yeah, so quite simply, it's almost impossible to make money from a business standpoint in EMS these days. All right, is that fair to say? And so if you are trying to make the bottom line make sense, it hurts the public health model, right? You're trying to stay solvent, and therefore you can't meet those benchmarks, because instead of covering just the city of Scranton, now you're covering the city of Scranton, Old Forge, Music, et cetera, with 1 ambulance. So as you've seen the contracture of EMS in our community recently, what you did not see is all the ambulances that we had all stay on the road. It didn't make sense from a business standpoint, right? And so what we're trying to do is shift that back to our public health model, and so we can lower those response times and improve public health with the resources that we already have.
Has somebody here tried to indicate that we were going to make money off of this?
Well, I don't think we're going to make money at all. That's not a goal at all.
No, I know, but you just mentioned that. We all know. I mean, if we're going to add ambulances, it's going to cost us probably $3 to $4 million a year to do this.
I think that's absolutely true. We're not here to make money. This is a
Right.
resource that we already have.
But just from the statement you said earlier, it made it seem like somebody up here.
Okay, well,
thought that we were-
currently our ambulance services are provided for by for-profit entities.
Right.
And so they operate based on a business model. We're going to operate more on a public service model.
Right.
And turn those times into priorities versus making the bottom lines match, right?
Well, it's my understanding, we are required to provide EMS services as a public entity, as a municipality, correct? So the way that we meet that model is we're relying on one ambulance company, a privately owned ambulance company. Like you said, it's a for-profit situation. So the problem there is we don't currently have any type of contract with them. Have we, as a city, if we were to sit down with them and develop a $0 contract with them, get them to sign it, and not just, under their terms, sit and meet with them and determine what is in the best interest of the city and the ambulance company, and get them to agree that, listen, this is what our response time needs to be, and get them to sign off on it. Like, to me, it makes a heck of a lot more sense than getting involved in, the ambulance business again, because there's a reason we came out of it. And the challenge for all of us is we spent 30 years in financial distress. 30 years. Well, I'm proud to sit here as a councilman and say that we have $3 million in our capital fund. Our S&P rating is BBB+, and that's because of a lot of hard work, a lot of money from President Biden and ARPA and things like that. But we've dug ourselves out. And believe me, I'm concerned about every citizen. There isn't anyone sitting in this room that's not concerned about every citizen that has a medical emergency. We absolutely want to address that and address it in the best possible way. But what my biggest concern is, if we go down this path and we start buying ambulances, which are incredibly expensive, and trying to equip them and try to train people and hire people at union rates, we are going to put ourselves right in a hole again. And I'm very, there's a balance here that has to be a very delicate balance.
So, Councilman, I understand your concerns, and let me just preface before Mr. Knight jumps back in here, and I know we're running short on time, but this is simply to give everyone the information on what this looks like. Are we going to move towards a more public health model, or are we going to stay engaged with the current model that's here? So there's two questions that I would ask any private ambulance provider who wants to do business with the city or sign on a contract. Number one, are you going to charge the city to subsidize the business if we put metrics in? And I'm going to let Mr. Knight talk on what's going on nationally with that. Are you going to charge us ask for a subsidy and a stipend from the city of Scranton if we put any metrics on you as far as response times go, quality assurance? And number two...
And if so, what would those...
And if so, what is that amount going to be? And number two, are you balance billing our citizens when the insurance that they have does not provide the total? Because they are out of network. They are in no network, the current providers. So we sit here, and you guys have done a phenomenal job over the years of, like you said, getting us out of distress status. And we always are concerned about any tax increase to our residents. That tax increase to a resident pales in comparison to what balanced billing does, hard billing by an EMS provider. Like I said, they are a for-profit company, and our model needs to be looked at from a public health model. So those are the two questions that need to be asked of them. What's that going to cost? And then looking at
Have we sat down with them and
we've had
discussed?
discussions, but the first thing was looking to see exactly what the national models look like. This is step one.
Sure.
Putting a study on the table on what the cost is going to be to the city. We wanted to give you guys every available choice to at least look at and start the discussion. We're not coming to you asking you for a decision on this, let's buy ambulances tomorrow. This needs to start a holistic conversation together and move towards a public health model that's the best for our citizens, that we can, like, to your point, Councilman, afford. But if that model, if we put those different caveats on a private vendor and go, here's what the response times that we want are going to be, here's where the quality assurances we're going to want, and we're going to want soft billing of our residents, and they come back and go, this is how much it's going to cost, and you look at our modeling and go, you could have greater control if you take it under the wing, which is under our umbrella, which is happening nationally. And the second point, I'll make one more point and then I'll turn it over to him. I know we're short on time. If that private ambulance provider closes its doors tomorrow, who's on the hook? We are. Ask the city of Reading what happened to them in 1999 when their under contract provider shuttered.
Well, that's why having a contract with them, you could build into that contract, say, listen, you can't, you got to, it's got to be 1 year. You got to provide the service, whatever. But that stuff can all be negotiated. So I'm glad we have all this information so that the next step can be the meeting with that company to say, listen, here's some of the things that we're looking for that we need in order to set up a contract.
Reading had a contract, and the ambulance company shuttered. They shut their doors. And the city of Reading stood up their own ambulance. Had to. Didn't have a choice because it cost. How much is the fine through the Department of Health if they go out of business? $100. If they pull out of a municipality, that's what they get fined. And then it's on us to get it back up. But I'll let Mr. Knight finish up real quick. Like I said, I know we're short on time.
Yeah, Chief, an excellent dialogue. So we'll send you the PowerPoint. Everything in the PowerPoint was in the report that's in front of you. So if you have time and inclination, all of the costing was probably the last 3-4 pages. And I think the big high-level takeaway I'd like to leave with you from a policy consideration is, as the Chief described, what we're seeing nationally and across the industry and basically was replicated here is that depending on how you want to staff, right, a non-subsidized system is getting rarer and rarer to occur in the industry. We did do our own kind of market research of what the unit hour costs would be and built a range of collections and a range of revenues associated with that. And the reality is, depending on how you staff, there's a mechanism where the cost difference between a private provider that you could contract with and providing it from your own municipal lens would be very, very similar, which probably drives a broader discussion on what's the value of having transparency, accountability, sustainability if there's a market failure versus contracting with another agency. So I just wanted to plant that seed that there's so much that has changed in EMS that description would not have been true 10 years ago, but it's absolutely true today. So when you look at the cost centers, I'll drive your attention to that a little bit, and I think I'll leave it with that unless you have any follow-up.
So you just mentioned staffing. So would the minimum staffing change because of the increased cost?
Well, I think, let me at least separate this, and the Chief can jump in if he needs to, but we're talking about two different things tonight. The doctor and the Chief are talking about doing first response to get EMS people there in a timely, efficient manner on those high acuity events, which is absolutely right, correct, and necessary. This study is talking about what's your risk associated with the instability in the market, and if you had to provide the services or wanted to start planning in that direction, this builds a framework of how many resources you would need, what kind of administrative capacity, the capital costs, all of the net general fund impact is what we built out to show you, depending on which level of performance you would choose and which types of staffing strategies you would choose. So like the Chief said, we tried to put a pretty broad bookends on there so you could have a lot of flexibility to go through the different models and contemplate what would be best for the city.
All right, well, thank you, gentlemen, for coming in. I believe we're going to have to continue this
Yes,
with a lot more to cover, so.
Thank you very much.
We'll
Appreciate it.
discuss
Thank you.
what
All of
else
you.
we're going to
Thanks,
do.
gentlemen.
Thank you.
Thank you.
Appreciate it.